Our next panel is on modern approaches to combat drug abuse with health information technology. And I have with me Shelly Edgerton. She's the director of the Michigan Department of Licensing and Regulatory Affairs. Because there's three of us, I won't read all of our panel, but she's been in this space for a while. She has a legal background in addition to being sort of front and center with a lot of policy type issues. And Larry Wagenknecht, who is the CEO of the Michigan Pharmacists Association. In full disclosure, Larry is also my boss in terms of he's chairman of the MiHIN board. So I'll be extra nice to him on this panel. And if I'm not, then it was unintentional. So, and then Laurie Wesolowicz, who is the director of pharmacy services at Blue Cross Blue Shield of Michigan. And both Larry and Laurie were on the recent governor's task force that really looked into the opioid space. And I went to testify about, hey, I think this health information technology stuff could be useful in this space. And I got there, and there were it went on for many hours, and so I listened. And there were at least 2 points in the series of presentations where I know I was trying to hide, how my eyes were moistening up. I mean, it was really a moving set of testimonies. And it was clear to me that technology wasn't the sole answer. And we had convened a bunch of mostly IT and operational folks to tee up a set of use cases, because we always talk about use cases in the IT space, that were related to medication management and really trying to advance communication about everything from what meds people were on to what kinds of things would reduce physician and pharmacist burdens for sort of knowing what was happening in the medication space. But when I got to the task force, it was clear to me that as a technologist, I didn't quite have a handle on the whole problem. And it's a big thing across the entire country. I think everybody here has probably knows someone, a family member or a friend who's had some kind of abuse type, opiate abuse type problem. So, and it doesn't seem to be shrinking in any way, shape, or form. It seems to be getting bigger. And so, what I figured out early on is that as a technologist, I kind of have my own view of things, that I'd like to just kind of go around and ask our panel members here, sort of what's your take from your vantage for what you've seen, either being on the task force or being in your current role. Where do you think we are in this space, and where, how would you characterize it from your own perspective? Larry?
Want me to start? Certainly on the governor's task force, there was a report that was put out. In fact, it's available online. It looks something like this, and so there's a variety of pages that go into the report. But really, the part that occurred on the task force itself was really trying to put a Michigan, define it for Michigan, as far as what is the impact of the opioid problem. And it really boiled down to a couple things. Michigan has a problem. We have a situation where there are more deaths that are occurring because of opioid abuse. We have a variety of crimes. Part of the governor's task force actually had all the right people in the room. It had law enforcement, so their state police was there. We had prosecuting attorneys. We had the Department of Licensing and Regulatory Affairs. We had community health. We had the Attorney General's office. We had, who else was, I'm trying to remember the whole cast of characters, but we had all the right players in the game, or in the room itself, as we were trying to address this. And it became very clear that there was an agreement of everyone there that something has to be done, and that just one little bill passing or one simple task would solve all of our problems. You know, the silver bullet doesn't exist. But it was a coordinated effort that we really needed to look at and to develop. So I think that this task force did a good job of kind of solidifying some different areas, some different recommendations, different things to do. But all of us on the task force, at least I'll speak for myself, I walked away with a better understanding of the problem that we had, because I had not seen some of the statistics and some of the bringing it home as far as what the trend line is. Everybody knows there's a problem. As you say, everybody knows someone who has had either a family or a death in your own family associated with it. But you don't really get a sense of, so what does that mean for the state of Michigan? And some of the statistics have a chart that's going off the chart, and recognizing that there's a lot of crime in the state of Michigan that is tied to some of the drug-seeking behavior of some of the individuals, and that certainly prescription drugs, the prescribing of some of the controlled substances. In our system, we have Schedule 1 through 5. A Schedule 1 controlled substance is something that's illegal, no approved medical use. Heroin, LSD falls in that category. To Schedule 5, which is less chance of abuse, less chance of for addiction associated with it. And so when we're talking about the opioids, we're really talking mostly in the Schedule 2 and Schedule 3 kind of space. And you know, those prescribing of those, it starts with that. And ultimately, because heroin is cheaper on the streets, when people run into challenges, into brick walls of their source not being there, they then turn to the streets, and heroin is actually cheaper than buying oxycodone. So this task force did a good job of really kind of defining what it is for Michigan, identified a variety of different ideas of how to fix some of those bits and pieces, but there's still a lot of work that needs to be done. I know Laurie might have a different or additional perspective.
You know, I think one of the most powerful days we had on the task force was when we actually had the public hearing. And, you know, people were invited to come and speak to us and tell us their stories. And I think one of the things that, you know, is been so enlightening is when we look at, you know, the faces of opioid abuse now, it's not those people over there downtown hiding behind, you know, dumpsters. It's people's children, and those children can be doctors and lawyers, and it's something that, you know, I think probably has touched everybody in this room one way or another. You probably know someone who's had an overdose. And, you know, just hearing the stories of how people have struggled, even people who have sought out treatment and received treatment, what a tough issue this really is. And it's really a disease that can be treated. So all of the things that, you know, you've heard today about quality measures and connecting providers with information really will help with this issue. But again, it's not going to be just the technology. It's really going to take a village to really solve this issue. And I think one of the most exciting things is that we're here today talking about it, and everyone is talking about it, because the past few years, it was really frustrating that we knew that there was this issue, but nobody said anything about it, you know? And when you think about the number of people who are dying every day of an opioid abuse, if there were dolphins washing up onto, you know, a beach, and that many dying every day, there'd be an outcry from the public. So it's wonderful now that the public is really, you know, learning more about this and what they can do in their own families, you know, to make sure that they don't have, you know, access to excess prescription opioids, because that's where it all starts. So I think that, you know, just the conversations about leveraging technology to address some of the issues is just so important.
Well, and I think related to Larry, I think bringing all the players to the table was very important. You know, as regulators, a lot of times we sit in a silo with different agencies, and you know, you talk about the problem of opiate abuse. Well, you know, MSP, state police is managing it one way, Department of Human Services is managing it a different way through their programs. You know, us as regulators through MAPS, we're looking at it a different way. And so it was kind of nice to have everybody at the table to talk and kind of breathe the same message of what we should be doing in terms of our recommendations and what direction the state should be taking, and honestly just putting a face on it. It is a real epidemic for everybody, and I think Michigan now kind of has their own face and their own spin for it, and to be able to have all the agencies to work collaboratively, I think is a big plus in solving the issues.
MAPS, you mentioned MAPS, the Michigan Automated Prescription Monitoring System. Is that,
right. Yep.
There were a handful of recommendations. I think there were a total of 17 recommendations, a good 5 or so really kind of had a little technology flavor. Could you maybe just share sort of the MAPS story there a little bit?
Yep. Laura has is Michigan Automated Prescription System. It's called MAPS. And in that it was established in 2003, so, and really hasn't been modernized at all. And so I think one of the questions that we were asked prior is like, what's the current status? And I want to say abysmal, because, you know, 2003 to 2016, even just in a software change, it's huge. You know, there's been some minor enhancements, but nothing to the speed of which our customers, our prescribers, and providers are used to. And so with that, and one of the recommendations to come out of the task force obviously was to enhance or greatly improve and or even just replace MAPS. And that's kind of where we're at today. We've been working with our legislative partners to get an appropriation to replace the system. We figured enhancement wasn't going to cut it in today's for what the analytics and everything that are needed for us to truly do the job in facing the opioid epidemic. So we will be going here shortly with a vendor that is APRIS, who is in 27 states, and be utilizing this. We've heard from a lot of our stakeholders who've seen demos and that would really be an upgrade in our system to be able to go there and have that availability.
It's fantastic. I know for about 3 years, the first time they asked, people were saying, well, we'd really like to get access to MAPS and be able to query MAPS. And for a while, I'm like, I don't know what MAPS is. And finally, we circled the wagons and understood it. And it's become clear that there's an enforcement component to the set of recommendations around providers going and checking MAPS and looking things up. And it's a pretty traditional website lookup. There isn't an electronic interchange. I get to stay in my EHR and do stuff kind of option. Are you envisioning that will be potential with a modernized version?
We're definitely looking at the integration, and we think that's a key component, and obviously we've heard from pharmacist groups, the providers, MSMS, and that in terms of that extra easy button step, I'll call it, you know, where there's actually the interface and integration into MAPS to make it easy for the providers and the prescribers to be able to just go right into it. We know right now with single sign-on, it's a clunky, time-consuming kind of step in the process for security purposes, and we are looking really to streamline that process. And we think a lot of the integration with the EMRs will solve that solution.
I think just to add on to that, I think one of the biggest challenges that all of the health professionals have related to MAPS, and to explain a little bit more what the Michigan Automated Prescription System is, it is a registry, a compilation of all controlled substances dispensed to patients in the state of Michigan. Every pharmacy and a dispensing physician who dispenses a controlled substance is required to report it to MAPS, to the state. And it's based on the individual, and it identifies some of the data that's in there is the individual, their doctor's name, the quantity of the drug, the name of the drug, those kinds of things. So that's what the MAPS system is. And the real challenge that the health professionals have today whether it be the doc or the pharmacist, is it's not integrated into our operating systems. In the pharmacy, it's certainly not in the physician's office as well. There's also additional limitations. When this was put into place back in the early 2000s, 2005 I think it was, or 2003, there was a lot of concern about privacy. And so today MAPS is very specific as far as who has access to it and who does not. And so there have been a lot of changes. The world has evolved a little bit since 2003. And certainly there's some upgrading that needs to occur. But the real challenge today for practitioners out there is that it is not integrated into their operating systems, whether it be at the pharmacy level or even at the physician level.
I think in looking through some of the recommendations, there were some potential policy or public health code kind of possible changes recommended there. And right now the model is kind of providers go to MAPS on sort of driven on their own. Is it, do we think it'll be feasible in the future for almost kind of a proactive alert or notification to ever come out so that it can be ready for the doc in that workflow or ready for the provider in that workflow?
Well, I think, one of our main goals first is just to replace the system. And obviously, I think, the integrations that come with the EMRs, the alerts, any of those things that we view as, and they may be even out of the box once we get into the system. But certainly we want to be able to provide those alerts, some of the equivalencies, any of kind of the newer functionalities that are apparent in a lot of other states. We want to be able to capture that as much of it as, one of our main goals, because we've been hit up, let's be honest, by a lot of people. Oh, we want this enhancement. We need this report. We need this. We're constantly, hey, okay, we'll put it down. But I think, overall, we really want to get a new system because what we have right now just doesn't work. And I think the value of that is getting that and then looking to see what the real needs are. We know state police wants access, the Attorney General's office, the DEA, all of our kind of partners in enforcement type actions want some kind of immediate action and access to it. And what we'd like to be able to do is get the system up and running, see what those next enhancements might be, and then go from there.
And I think it's important to note, as Shelly identified, any changes related to that is going to require a change in the public health code. Because the public health code is very specific as far as who has access or who does not.
It's very prescriptive.
Very prescriptive.
Very prescriptive.
And so that is one of the challenges, and Shelly's exactly correct. The DEA has been, asking for information, and it's not that they can't get information, because, or even in state police, they can get information, but there has to be an active case in place and some of those restrictions. So the real challenge is that some people believe that once Shelly turns on the switch on whatever the new MAPS system is, or whatever it looks like, that instantly they'll all have instant access, and that probably is not going to occur because of the need of changing the public health code.
I want to shift the conversation a little bit. So there's sort of the maps and the technology piece, but then there's also the sort of, okay, what do you do after something has been detected? And I'll shift the question to Laurie a little bit and just say, what does Blue Cross Blue Shield of Michigan have in place or do to identify potential opioid abuse, and sort of, what happens when you do?
So, we've kind of gone through an evolution of data analytics related to opioids. Back in about 2007, we did a lot of work just trying to identify who were the highest users of opioids, who were the highest prescribers, which pharmacies were they being dispensed from. And, we've put in interventions through the years to really address that. We've worked individually with certain patients. Just to give you an example, we identified a patient that was using an opioid called fentanyl, which is actually the drug that Prince overdosed on. And this patient was using it in a lollipop form. And, you know, he was actually using probably 3 or 4 of these lollipops an hour based on the amount of drug that he was taking. We thought there was no way that he could actually be taking that much and still be alive. And so we sent out our investigators, our internal investigators, to go meet with him. And they met him at his house, and as he's getting out of his car, he's actually got a lollipop in his mouth. And lo and behold, he was actually using all of those lollipops. He had some chronic pain issues and just kept escalating how many he was actually taking. And, you know, it was a real issue because this drug is so dangerous. If he took 5 lollipops 1 hour, that could have caused his overdose death. So what we did is we didn't just throw him in jail, which is what, you know, people would have done in the past. We work with a consultant addiction specialist who, believe it or not, was able to take this patient from using all of these lollipops at a really incredibly dangerous dose to right now he's on nothing. And so, you know, by, you know, using our data to identify patients that were in need, we were able to many times give them the right care that they needed to either reduce the dose or get them on the right amount of medication that they needed. You know, we've also done some things where we don't cover prescriptions for certain prescribers within our state. We identified many physicians who we knew were prescriber mills, and so working hand in hand with law enforcement, many of them have been indicted, or before that actually happens, we've actually stopped prescribing. One of the more exciting things that we're looking at right now to do with our data is related to identifying patients that have already had an overdose. And there was recently a study that talked about how about 20% of patients who overdose on an opioid, once they get discharged from the emergency room or the hospital, they go right back and they get another opioid prescription within days to weeks. And guess what happens again? They overdose again. So, you know, when you think about it, that's so dangerous, but then also you're seeing, you know, increased healthcare costs just because, you know, this person keeps having access. So what do you do? So one of the ideas that we've had is to leverage our admit, discharge, transfer information that we're getting from healthcare facilities now and try to boil that down to really identify which patients are getting discharged with an opioid overdose diagnosis. And what we're going to do with that information is hand it over to our behavioral health case managers. Because when you think about it, when someone has that near-death experience, they're usually willing to talk to somebody about it. So we're trying to determine if by leveraging that information, we can actually get people into substance abuse treatment sooner, and also contact those prescribers, because what they found is many of those prescribers who gave the patient the original opioid prescription had no idea that they overdosed. And so they get a phone call saying, hey, I need more prescription opioids, and then they give it to them. So we're really trying to figure out, can we use this data that's flowing in now to really devise a program that we can not only just use internally to identify, but also work with our physician organizations that they can figure out how to mine that data so they can identify people that they need to reach out to as well.
That should be very exciting. And that's, you said ADTs and then discharge med recs.
Yep, bring them all together.
Complete the package. Discharge med recs have problem lists and medications as sort of one of the big components after every discharge. And so be excited to see how to mine that and get that there. Larry, what if I were to line up like a bunch of pharmacists and ask them what needs to happen, what would they say is the right thing to sort of go forward, either, you know, both technology and just, you know, make their life better?
Do we have all day?
No, we don't have all day.
Okay.
So,
Okay, we have 35 minutes. Okay, so because we're between now and the happy hour. Probably the biggest challenge today is the difficulty in obtaining information. So certainly related to the opioid issue, yes, there's the MAPS program, and MAPS will provide us some information related to the individual. So the lack of integration into their normal workflow is certainly a challenge. At the same time, there are also numerous problems and challenges, not necessarily just opioid-wise, but otherwise, of getting information and understanding what the prescriptions are being prescribed for. Today, when most pharmacists in the ambulatory setting, unless they have access to the EHR or EMR, the pharmacist is flying blind. Other than whatever the patient tells you. There are some medications. Now, in our office, I'm a licensed pharmacist, but in our office, they consider me clinically dead. So, they avoid all questions related to appropriate drug use. They avoid, kind of shunt me away from that. But the reality is that pharmacists may know about what the drug is, but usually there's more than one indication for a drug. And so the challenge really becomes of trying to understand what the goal the physician is trying to achieve with prescribing that particular product. When you see an opioid, obviously it's pain, but you have no idea of the full extent of what it is. And is it chemotherapy related? Is it broken ankle? Is it root canal? All of those kinds of things are out there. So the pharmacist flies blind frequently as far as really trying to understand and making sure that the correct dose is given to the patient for the right purpose. And the pharmacist does have an obligation to assure that there's a medical need for that particular product. Part of the challenge that the pharmacists have is because of this medical need, they are required, as that one piece that they must do is assure that there's a medical need. So the pill mills that are out there and physicians who are prescribing and pharmacists that are dispensing, those are bad situations, and unfortunately Michigan has had a lot of those.
What's a pill mill?
A pill mill is a physician who writes prescriptions for a patient, may or may not actually complete an exam, and they literally line up on the street and pay their dollars, come in, and walk out with a prescription. That's not the norm. That's not the normal physician protocol, but they exist out there. And in fact, Michigan, both in the East and the West Division of the U.S. Department of Justice, are constantly looking at different entities that are out there, and Shelly's gang is right behind and working in cooperation and trying to close those. And in fact, they have. They've done a very good job. But because of demonstrating this, the medical need does become a challenge. Most of the problems, and Laurie is exactly correct, the day that we had the public hearing that you attended as well, Tim, there were a lot of stories. Unfortunately, most of the individuals who are on heroin talked about they started out on a prescription drug for whether it be an ankle break or some other pain that the physician or dentist prescribed for them. And so the pharmacist cannot dispense the medication without a physician writing a prescription for it. And so our challenge is how do we question the physician? And there's obligations that pharmacists do contact the physicians frequently. Other challenges that the pharmacist has is as some of the pain clinics are shut down, there are instantly individuals who need their medications, and in addiction, it's not, if a person is addicted to opioids, it's not that they just they think they need something, but literally their body needs it. And so, in fact, we had 2 or 3 individuals at the hearing who had recently been shut down and they were on the verge of going into withdrawal. And so it was quite moving testimony of what they talked about. But the pharmacist is also in a very difficult situation because they see the patient eyeball to eyeball and trying to recognize what resources do they have to reach out to try to get this person directed into place to help. So those were just a few of the challenges that the pharmacists have related to this issue, and then just the whole lack of information or access to information related to the greater, broader health information on a given patient.
One of the things that surfaced at that session as well related to just sort of coverage and people being able to have even the program you meant. Do all employers, I mean, is there a requirement for folks to offer coverage in this space? How does that work exactly?
So, as a health plan for the members that we actually insure ourselves, we do provide, coverage, and, if somebody needs additional treatment, there are ways for people to appeal that. On the self-insured employers, most do provide some level of substance abuse treatment, but, they have the ability to dial up or dial down, what they actually want to provide in terms of coverage. And sometimes it's, all around cost and not necessarily quality of care. We do have some employer groups who won't cover the treatment for addiction. It's called Suboxone, which is one of the main types of drugs that's used to treat opioid addiction. And some employer groups have said, no, I don't want to cover that because it's too expensive. So, overall, people do have usually good coverage for substance abuse treatment. I think one of the real challenges in Michigan is identifying substance abuse treatment facilities in quantities enough to really deal with the number of people who have the disease now.
Shelly, is your office involved in the sort of licensing of those folks at all, or those pain clinics?
In terms of the pain clinics, we will be.
Okay.
Yeah, we do have, there's some oversight now. I wouldn't necessarily say it's one of our true licensing programs.
Okay.
Part of the recommendations, and I know there's been some discussion with some of the legislative partners that they'd like to do a little bit more regarding that program. What does it take to actually be a pain clinic? What are some of the necessary regulatory steps they need to go through? And how frequently would we go there, and the records that need to be kept in order for us to actually have some oversight.
And is that sort of co-linked with MAPS and its evolution, or is that like a whole nother thing?
I think that'll be a whole nother thing. Yeah,
Okay.
I think obviously there could be some interplay at some point, but when you begin to license a facility, it's slightly different than we would envision with the MAPS.
I think one of the things, Tim, that keeps popping up is the challenge that the health professionals have is that the number of bad players out there is a relatively small number as far as physicians prescribing, pharmacists dispensing in the pill mill situation. But the number of individuals who are becoming addicted is increasing. And so the challenge is making sure that we still have access to the pain meds for those who need it, and somehow trying to differentiate those who need it versus those who have some addictive behavior or drug-seeking behavior. And that's a very, very fine line that it's really difficult to define in a rule or a law of who should have it and who shouldn't have it. And that's been some of the struggle that I think our task force tried to struggle with a little bit, because you got the hand of the law that wants to stop this, and then you have the practitioners on the other hand, patients who need it, and making sure that we're not all artificially creating some barriers that prevents patient care from occurring.
So we had the quality task force, the quality panel earlier, and I just wondered if this issue came up on the task force. I've heard it from physicians, and I don't have a physician on this group, so I apologize. But the way that we we enforce quality measures. There's some patient satisfaction questionnaires, and there's a questionnaire that's pretty common, is sort of how well did the doctor manage your pain? And was it mentioned on the task force, or was there any substance to the argument that there's some systematic enforcement or reinforcement of that, because we're kind of asking, on a scale from 1 to 10, how much pain are you in? And some people have never been in pain before, and so it's their first time with a wound, and they go, I'm a 10. And so the doctor has some incentive to kind of load them up so that their pain can be managed, so they don't get dinged on the how well was your pain managed scorecard. Whereas somebody else, maybe this is the 3rd time they've been shot, and they go, yeah, it didn't hurt that much, yeah, it's maybe a 6, last time was worse. I mean, was that brought up at all, and how was that concept handled? I didn't sort of see it called out in any of the recommendations with any obvious place I can make a connection.
Yeah, I think it's being discussed more at the national level. When you talk about some of the accreditation organizations like the Joint Commission, they've been always, pushing the pain as the 5th vital sign. And so, physicians felt compelled that they needed to make sure that everybody left, pain-free. And I think they've, recognized now that that was part of the problem. One of the things, that prescribers can do is be very thoughtful, when they're assessing someone for pain, and if they feel that they're appropriate to receive an opioid, they can certainly, if it's an acute pain situation, limit them to a certain amount of pain medication. But if it's someone who looks like they're going to need a more chronic, supply of opioids, they can actually make a contract with that particular patient. And typically, if you talk to physicians, they treat patients a lot for pain. Part of that contract is that the physician will check the MAPS program on a regular basis to make sure that they're not doctor shopping. So, I think everybody recognizes that, some patients are going to be looking for drugs, seeking them out even though they don't have legitimate pain. But those tend not to be the patients that are going to fill out a survey form. But patients who really do have legitimate pain and the physician wants to be responsible, they can utilize both, that agreement, but also technology can help them make right decisions for follow-up opioid prescriptions.
So Shelly, we give you carte blanche to do whatever you need to do and be in charge. What would you do, and what order would it happen in?
Yeah, it'd be great to be queen for the day, as we say.
Yeah.
But
might take more than a day. So
might take more than a day.
In this scenario, pretend you got a couple days.
One of the goal, obviously as a regulator, one of the goal is not necessarily to do enforcement, but to bring people into compliance and make sure they understand the rules and the requirements of what they're supposed to be doing. So, I think by ensuring, education of the prescribers, the providers, we can bring about kind of a more robust system. But, obviously we want to enforce when we have to. Laura, and a lot of this has been evolved since the task force. We created, the director created the bureau director, Kim Gatica, corrected a pilot program to really kind of have a dedicated staff to enforcement. And I think we're seeing real results in that. We were able to knock out 2 of the 2 doctors to suspend their licenses for overprescribing, and it was that concentrated effort. So I know, if I got to be queen, if we could have a more evolved, robust system with those individuals or pilots in terms of our enforcement, it would help us. And obviously a new system that gives us better analytics all around will help us in that fashion. So those would probably be the 2 key things I'd be looking for.
Okay. Laurie, if we
I'll pass my crown.
Pass the crown over and let you
kind of
lead. Where would you take us?
So what I would like to see is that before any prescriber, whether it's a physician, nurse practitioner, physician assistant, use all of the tools available to them to make a clinical decision, you know, before they write the prescription. And it's not to even write the prescription anymore. I really want to see prescribers utilizing electronic prescribing of controlled substances. You know, we know that only about 30% of physicians use the MAPS program. And, you know, I'd love that to be 100% once the system is upgraded. Right now in Michigan, we're up to maybe about 7% of prescribers using electronic prescribing for controlled substances. We want to see that way higher. When you think about one of the easy ways that people get the inappropriate supplies of opioids, they steal a prescription pad. And believe it or not, it still happens today. We send out reports to physicians that have patients that go to lots of different prescribers. They call them doctor shoppers. And we always get phone calls back that I didn't write their prescription, they stole my prescription pad. So by utilizing the electronic prescribing tools to prescribe controlled substances, that problem goes away. Also, too, the physician can see what else they've been getting. So my wish is that we can start using the tools that we already have available to us.
What needs to happen to get that e-prescribing? What seems to be the barrier? Because we do have pretty high e-prescribing for other kinds of medications in Michigan. We're doing pretty good on that front.
Yeah, you know, I think the controlled substances is a little bit different. It does take some effort to get authenticated. And, you know, one of the big challenges physicians have now is that it's a different process for them in their office. So we're pretty serious about promoting this, you know, prescribing way at Blue Cross. We actually have implemented in our physician group incentive program an incentive to improve electronic prescribing of controlled substances. And we also made it one of our social missions, our social mission goals for the next couple years. So we're really serious about, you know, supporting the physician community in electronic prescribing.
Larry?
As queen for the day.
If that works for you, that's great.
I guess what I would really like to see is the two-way flow of information from pharmacies to health plans into the patient's electronic health record. Pharmacists have been computerized since the late 1970s. 1980s, there were protocols put in place, and since the early 1980s, virtually 100% of the prescriptions have been electronically transmitted from the pharmacy to the pharmacy benefit manager or insurance company, whatever the situation might be, and then real-time adjudicated as far as identifying whether the drug is covered, what the patient's copay is, whether the patient is covered, et cetera. And we've had challenges because back in the early 80s, there wasn't anything called the electronic health record or medical record. And so there were standards that were established back then, and there have been a variety of changes that have occurred through the National Prescription Drug, NCPDP, the National Council of Prescription Drug Programs that is out there. And unfortunately, the NCPDP format does not integrate with HL7 and some of the other more recent changes and transmission of data kind of activities. So creating that pathway of a two-way communication, I think, would be my greatest wish, which then would provide physicians information of the fill status, automatic stop orders, all those kinds of things could go two ways of sharing information that the pharmacist could share with the prescriber, and likewise the prescriber could share with any or all of the pharmacies that are out there.
So it sounds like we need a pharmacy fire project that we can get everybody aimed in the future. Okay.
Just pass out some magic wands. Those are good.
Well,
I use mine already, so I need some more.
We have time for a couple of questions that we'll entertain. So if we can get some microphones circulated, and we'll start right over here first.
Great discussion, thanks. I think you guys touched on a lot of the key points. The one I didn't hear, I think is critical too, is better availability of drug disposal. You know, everyone and their brothers got these half bottles hanging around, and it's just not easy to get rid of them. And a lot of that ends up being the cause of pediatric overdoses, you know, found bottles, lots and lots of morbidity related to that. So what are your guys' thoughts about that?
The task force actually did call out that as an action area. We did talk about it.
That is absolutely one of the biggest challenges, just as you identified when a patient obtains a pain med, and I'm guessing most of you probably have an extra bottle in your medicine cabinet. I know I'm guilty of that I carry around with me from my dentist, that some extra pain pills. But it is a huge source of overdose and challenges with children getting into it. The governor's recommendations had several recommendations of expanded drug take-back, and in fact, Michigan has done some of that over the last couple of years, and allowing pharmacies to take back meds. Obviously, the cost of the disposal continues to be one of the challenges, but it is a noted piece of public education that really needs to occur out there.
Over here.
Hi, Mike Kelly, Trinity Health. I have a two-part question. First question, I guess, is we were talking, we have a national EMPI that we can actually track patients going across the country and then back, frequent flyers. I was wondering if there's any capabilities to capture that kind of information and data as patients are going from ED to ED. And second, I was curious too, are the states working together to try to combat these kinds of things, and what kinds of efforts are going on there? Thanks.
So the first question, I'm not sure I quite heard as a question. Could you say what that question is?
So we see a lot of frequent flyers, people going from emergency departments.
The same person going from state to state?
Just within our hospitals, yeah.
Okay.
So I was just curious if there's any ways of detecting that.
Is there a multi-state initiative that you are, or interstate initiative that you're aware of?
Well, you know, I think overall MAPS, I mean, we have, you know, a prescriber, has the ability to look at the patient, look at the addresses, all the information contained in that particular record. They do have the ability to search other states if they're in the master hub. And so it is a slow process. So I think sometimes the data coming back is slow. So I think the frequency of prescribers actually searching for that kind of information, I think why they do it, I think we trend behind it. But we do have that effort, and certainly we're hoping that with the new system, it'll be a real, quick, so especially Michigan, around the border states, Ohio, Indiana, Illinois, you'll be able to kind of track a patient if they're kind of coming in and out along the borders especially.
I think there was another one over here next.
Yeah, a question. I have a cousin who just did his dissertation on opioid dependency in older Americans. And one of the things that came out in his dissertation was the mental health aspect of it. And did you guys discuss that in there? Because it was a chronic behavior that happened over time, and it was a cycle that couldn't be broken. And so some of this information we're talking about as far as passing on would be very helpful to those behavioral health people to help get those people engaged and get them off.
I think there's, a lot of recognition that opioid addiction is truly a mental health issue. And, what many, physicians are referring to is called substance abuse disorder. And, the integration of mental health is just so important. And actually there's a big push even to get more integration between mental health providers and primary care, because a lot of the primary care providers are the exact physicians that'll be caring for those older patients. So I think between recognizing that this is a mental health disorder, plus making sure that there's more integration between the primary care and mental health providers, that's a win-win. And I know at least at the health plan level, we're really trying to work hard to make sure that all of our physician organizations have mental health integration within their services.
And it might be a situation too where, because the opioid issue is such a big issue, it's actually driving more and more discussions of the behavioral health side with the medical side. And so, this may be one of the issues that might be one of the driving forces that brings more attention to it.
In talking to some of my counterparts around the country, people are beginning to believe that the resolution of the opioid challenge is one of these great social determinants galvanizing places to tackle interoperability, because it brings together the health system, it brings together the sort of state, and it brings together a lot of these other services. It's very tangible, it's very actionable right now, and so it's actually kind of burning a path through what needs to be connected and tied together. So I think this particular issue is a great interoperability space to sort of make this stuff work, because it touches everybody. You can't find somebody when you pull on the string that it doesn't touch. I think there was another question over here. Oh, sorry, I didn't mean to skip.
A couple of weeks ago, Anderson Cooper had a town hall on opioids, and it was outstanding. There was a young man who had been an addict and had received the proper treatment and had recovered fully, and then he was in an accident, hospitalized. They didn't have his records, and they put him on the pain management, and suddenly he was an addict again. I was wondering if you could react to that.
It's one of those tough situations where it would have been great to have had the patient's record, but depending on what the trauma was, they need to treat the patient's pain. But by recognizing that the patient already had a history of substance abuse disorder, they may have chosen some different types of medications or minimized. The hard part is once somebody has, an opioid addiction, they have it for the rest of their life. It's a lifelong illness. And so that's really the challenge, though, that a lot of physicians have now, is that you still have to treat the pain, especially if it's related to a trauma. But having that information would have probably helped them make different choices.
Go.
Oh, we're going over here? All right.
Okay.
Yeah, sorry. We got a lot of lights up here.
And the lights are bright up here.
We're not trying to be...
I hope I have
Go
two.
ahead.
These are two quick questions. So the first one is around the modernization of MAP, and I'm sorry if I missed it. How far away do you think we are from improving it or changing it? And kind of the second part of that question is in terms of changing the public code, can that be done kind of in conjunction so that when you do flip the switch, you have, the code is there to say that these individuals have access?
Well, to your part, we are right now, the legislature has the appropriation in front of them right now. We would expect that will be passed this week. We know that the legislature is going to be out for summer recess. So once that's signed, we're already making the preparatory steps, taking everything that we can possibly do. So once we know that we have the money available to spend, we can start on it. I would suspect if we can get started by July, we might very well have, something by this fall where we would be able to do it. The public health code amendments that are going to talk about the access, that's going to take a little bit longer. I think everybody has talked about it, the mandated prescribing, greater access for law enforcement, AG, health prescribers that do research. that's probably going to be a little bit different effort, and I would suspect that we'll see a lot of the opioid task force related recommendations that require legislative change to probably happen more in the fall. I think, the MAPS rewrite and this appropriation is kind of jump-starting a lot of it, but a lot of the bills are just trickling through right now. I just don't think those changes will take effect in maybe till fall.
And
There's also some, it's been unclear thus far, Senator Shirkey, who's chair of the Senate Health Policy Committee, has, of which many of those bills will likely go through, has been somewhat lukewarm related to some of the various solutions, quote unquote, that are out there, asking for kind of a greater look at, is this really going to solve the problem, or is it just because it's an election year that everybody's trying to have a bill passed? So he's somewhat pragmatic from that standpoint. So that's the only other thing to add to it.
my second quick question, hopefully, is that, there was some talk about having physicians have the right tools available to them, be able to maybe more comprehensively look at a chronic pain patient. So I'm wondering, in the discussion in the task force, was there some discussion around what those tools were? Is there, an EHR-based tool that helps a primary care physician monitor a chronic pain patient over time? Is there some talk of looking at that so it makes it maybe easier and more effective for that primary care physician maybe to look at those patients over time and make a more appropriate, I don't want to say, not that they're making non-appropriate, but just what's a better maybe pain medication for a particular type of patient versus going to an opioid?
In the report from the recommendations, about as far along as I saw in that was promoting integration so that there's electronic ways to sort of tie things together. I don't think I saw anything about specific new physician tools that would layer in on top of EHRs. I mean, I don't think they made it that far. I think we got a really old system, we got to bring it up to the modern era, then we got to change the way it talks to the rest of the world so it's a little bit better.
We did review, there are some states, Ohio, for example, does do a opioid equivalency or some tool that's there to help that out. We did not get into the nitty-gritty of specific tools, other than recognizing that they are out there, but we did not get into any specifics on it.
And to that, Larry, I mean, the morphine equivalency is kind of one of the extra, enhancements that we're looking at that we think the new system will have. Plus an alert if somebody is actually, a particular patient is kind of red flagged for potentially going to a doctor shop, that we would have those tools. Other than that, I think those are the basic, integration type tools that we were talking about.
Just thinking about, we've done such a good job around, diabetes management where they have dashboards, they can see how well they're doing in terms of taking care of the patient. We don't really have anything like that for pain where you're looking at that patient over time that can maybe help you, change or, alter the pain medication that the patient's getting.
Let's go with our last question.
Yeah, I had actually, this was close to my heart 3 years ago because I had actually worked with the state of Michigan, the MAPS. Tim Wassel was there, that we actually tapped your database to track drug shoppers with one of the large physician groups in the state of Michigan for 7 days and found a number of drug shoppers. The issue is, the doctors can print up that MAPS data, and this actually, in this practice of PharmD, did print that every Monday, but the doctors are so busy, they don't look at it, so you got to get it into their workflow. Mm-hmm. So at Dr. First, we actually incorporated that into the workflow of the e-prescribing tool, so they would see that data on any patient before they actually make that prescription, and that's where we were able to catch the patients that were drug shopping. The pharmacist, on the other hand, he's the one that logs in all that data, but he never gets to look at that data. Even when a patient comes in, for a second prescription or anything, he has no idea they're a drug shopper a lot of times, which is one of the issues in the program. But a priest is the kind of the hub for all the 28 states. And they bought that program from the Ohio hospital there in Dayton. NarcCheck is the system that they have developed. The National Association Board of Pharmacy actually owned that product and has sold it now to a priest so that it is available to be able to check. It gives like a rating on the patient if they're a high-risk drug shopper or if they're a low-risk drug shopper. So I know there's a couple states that are using that now. But it is a real problem in all states. I know how Ohio is, the southern part of our state of Ohio is a real trouble area, and they run to Florida to shop for drugs as well. So you've got people that, this is an epidemic problem that we still need to address much more aggressively anyway, in my opinion.
Thank you very much. With that, I'm going to ask you to thank our panel.